If you've seen any of my previous videos, you know that integrative psychiatry is not alternative psychiatry. Integrative psychiatry is standard of care medicine with extras, usually very low risk extras that can augment the effectiveness of psychopharmacology. So in this video, I'm going to be going over my high yield integrative protocol for bipolar disorder and giving specific examples of how this protocol can be used with patient cases. I'm Alana Miller, MD, an integrative psychiatrist and private practice owner who mentors psychiatrists and psych MPs on building their integrative psychiatry private practices. So let's get started. So I've got the protocol pulled up here. And by the way, if you'd like to get a copy of this protocol, click the link below in the description and you'll get access to my free training webinar on how to build an integrative psychiatry private practice, and a copy of this protocol will get emailed to you as well. Okay, so first let me clarify what this protocol is for. So this isn't necessarily for patients who meet criteria for bipolar 1, but rather meet criteria for bipolar 2 or do not meet criteria for either bipolar 1 or 2, but appear to be on the bipolar spectrum with bipolar features that don't seem characteristic of unipolar depression. Now, approaches that are on this protocol you can still use in patients with bipolar 1, but you're not using them at the expense of following standard of care practices with mood stabilization medication. So first, when do you consider bipolar spectrum illness as opposed to unipolar depression? So there are certain non-manic markers. And by non-manic markers, I mean these are historical features of the patient's history that don't have to do with symptomatology related to manic symptoms, and yet tend to indicate that the patient is on the spectrum. These kinds of patients tend to do better on mood stabilizers rather than antidepressants. They tend to have side effects from antidepressant medications like SSRIs. So example non-manic markers: positive family history of bipolar illness or severe major depressive disorder. I think we all know that. A personal history of severe major depressive illness. So the more severe major depressive episodes a person has, the more you want to be thinking that they might be on the bipolar spectrum. Early onset of first depressive episode, so teens or early 20s. For women, a hormonal component to the mood symptoms. So PMDD symptoms that get worse around the menstrual cycle, or mood symptoms that get worse around the menstrual cycle. A seasonal component to mood symptoms. So patients who do worse in winter seasons than they do in summer and spring. And this is true even in LA, it's where I live. It has less to do with the weather as it has to do with the angle of the sun in the sky and the amount of exposure to light that patients get during the day. Rapid onset of depressive symptoms. So even when the patient's going into a depressive episode, there tends to be a rapid switch rather than a slow onset over the course of a couple of weeks or so. It's like they wake up one day and they're very depressed. That you want to be thinking of bipolar spectrum as well. Now, another one is multi-antidepressant trials, and especially with SSRIs that haven't worked. And often what happens with these patients is they might have agitating side effects from antidepressants, or they might have a tendency for an antidepressant poop out effect, meaning that the SSRI works for a couple of months or even a couple of years and then wears off. Then they get on another one. It works at first, wears off. If you have a patient who has a history of that happening multiple times, I want you to be thinking of bipolar spectrum. Now, this is from a book called A Spectrum Approach to Mood Disorders by James Phelps, so I'll link to that in the description as well if you want to get a copy. Now, in addition to getting a history with the patient, rating scales and questionnaires can be useful as well as screening tools. Now, in terms of lab analysis, I'm sure everyone knows how to order a CBC, order a TSH, rule out basic abnormalities on the labs. However, what you can do with an integrative approach is have a little bit of a keener eye in the way you interpret labs. So here are the labs that I recommend for bipolar disorder if you have a patient that you're evaluating. The bolded ones are the highest yield. So obviously CBC with DIF, you want to be evaluating for anemia or borderline functional deficiencies in like B vitamins or iron that will affect the size of the red blood cells. Metabolic panel, mostly because you might be starting medications that might impact creatinine or impact liver function. So it's good to have a baseline level. Fasting lipid panel, if the patient hasn't had one in their annual screening. Hemoglobin A1C as well. Again, not because you're going to be treating patients who have diabetes yourself, but you might be giving them medications that could put them at risk for that. So you want to have baseline levels. Now, vitamin B12 and folic acid panel. In addition, you want to be checking homocysteine and methylmalonic acid, which are functional markers of B vitamin deficiencies. And as well, I recommend a thyroid panel. At the very least, a TSH with a reflex to free T3 and free T4. But if you have any suspicion that this patient might be hypothyroid or like has a family history or personal symptoms, especially like low energy fatigue is a symptom of their depression, sometimes I will just throw in the TSH, free T3, free T4, and antithyroid antibodies. Now, you don't want to just be looking at normal ranges. So, for example, vitamin D, the low end of the normal range is around 20 or 30, depending on the lab panel you're looking at, but you want to be optimizing patients to a level of 50. With TSH, anything over 4, depending again on the lab panel, is typically abnormal, but really anything over 2.5 you want to be paying attention to. And it's not like you're going to treat a patient with a TSH of 3.5 with Synthroid, but if they're depressed and you need an augmenting strategy for their depression, you might consider then Cytomel in that case, because Cytomel is used even in euthyroid patients for antidepressant augmentation, but you might especially think of it if the patient has borderline abnormal thyroid function. I think that one of the strengths of integrative and functional psychiatry in this case is that we learn how to interpret lab panels outside of just what is obviously in the normal range, meaning you can observe patterns. I'll give you one other example. Vitamin B12, typically the normal range is anything over 200 is normal, but really anything under 400 is abnormal and you should supplement. And the other things that will show up in patients who have borderline functional B vitamin deficiencies, especially B12, will be they'll have a borderline low B12 level, like 300 or something. They will have a high homocysteine or borderline high homocysteine. Normal homocysteine is anything under 10, but anything over 7.5 you want to be paying attention to. So maybe they'll have B12 of 300, a homocysteine of 8, and then you look at their MCV on their CBC. This is the size of the red blood cells. Anything over 100 is abnormal. Again, remember B12 or folic acid deficiency anemia, blood cells get big. Iron deficiency anemia, they're small. So what you'll start to see in patients with these functional B vitamin deficiencies is the MCV is getting up to 100, but it's not quite there. So you'll see maybe an MCV of 97. Now, if you have an MCV of 97, a B12 of 300, and a homocysteine of 8, every single one of those values is going to be in the normal range, is not going to get flagged. However, that shows a very obvious pattern that this patient is functionally deficient in B12, and you should supplement them not just with a B12 vitamin, but generally with a B complex. You want broad spectrum supplementation. Moving along. Now, treatment. I think everyone knows standard of care medication management for bipolar disorder, bipolar spectrum. Lamictal is extremely useful in these patients. So if you have a patient, especially who tends to always have agitating side effects from antidepressants, consider Lamictal. I've had patients even with generalized anxiety. Depression isn't their main symptomatology, but they get so much better with Lamictal as opposed to SSRIs. Also consider low dose lithium. We're not talking about bipolar 1 dosing where you're optimizing for a level of 0.8 to 1.2. We're talking like 75 to 300 milligrams of lithium. Now, antidepressant dosing of lithium is usually around like 600 milligrams. You are optimizing for a level of around 0.6 in that case. But even these little baby doses of lithium can be neuroprotective and have very few side effects. You really don't have to worry about monitoring lithium levels or even thyroid function or kidney function. It's good to do, but it's not necessary at those doses. Again, consider T3 or Cytomel as an augmenting strategy, especially if you see the patient is borderline abnormal in their thyroid function. And use atypical antipsychotics judiciously. Don't just throw Seroquel at a patient like this, especially for sleep. Oh my gosh, it makes me go nuts a little bit when I see that. We don't want to be giving patients diabetes and hyperlipidemia for no good reason, or metabolic syndrome for no good reason. If you're going to use an atypical antipsychotic, really try to use one that is weight neutral. Now let's get on to the nutraceuticals. And this is where integrative psychiatry can get really fun, where you can add on these things that will augment the effectiveness of the medication management you're doing. Now, I bolded the highest yield things in bold. Fish oil. If you have a patient who's bipolar or just unipolar depression and they're not on fish oil, I would ask you why. It's incredibly low risk and easy to take, and there's plenty of research that it's effective. Sometimes I hear people say, oh, there's no evidence that fish oil works. And I'm like, for what? What indication are you talking about? Yes, there's studies where you just give it to a whole population that it may have marginal utility for like heart disease. However, if you're giving it for a particular indication at a therapeutic dose, in this case, mood symptoms, this is not controversial. It is effective. Now, N-acetylcysteine, this is again extremely low risk, probably not as effective as fish oil is, but there is some research that's helpful for mood stabilization, and it also is hepatoprotective. And so it tends to, in addition, be good for obsessive symptoms like OCD or just obsessive anxiety. So if you have a patient with bipolar disorder or mood disorder and is also on the OCD spectrum, I would add N-acetylcysteine because you're kind of getting two birds with one stone. Again, most patients are going to benefit from a methylated B complex. When I say methylated, I mean that it has L-methylfolate in it as opposed to folinic acid. Not to get too much in the weeds here, but many patients that we see have variants of the MTHFR gene, which means that they do not efficiently convert folic acid to L-methylfolate, which is the version of folic acid that crosses the blood-brain barrier. So you can test MTHFR, but honestly, there's no harm to just assuming patients have these variants and supplementing with L-methylfolate. And then again, get people's vitamin D up to 50. So in most cases, you have to supplement. Now, magnesium threonate or glycinate is also a very high yield nutraceutical that you can use in this population. Just to give you a little background on magnesium, if you're buying magnesium over the counter at like CVS, you're probably getting magnesium carbonate, which is a terrible formulation. It's not very absorbable, and it definitely does not cross the blood-brain barrier. If you get a slightly more expensive magnesium, you're probably getting magnesium citrate, which is very absorbable. I don't know why I can't pronounce words right now. Absorbable. However, it does not cross the blood-brain barrier effectively. Magnesium threonate or glycinate, it's absorbable, but it also crosses the blood-brain barrier very effectively, and so it's good for any kind of psychiatric type symptom, and it tends to be very relaxing, and it helps with sleep. I actually encourage you, go buy some and try it and tell me you don't feel more relaxed after taking it. And you can dose pretty highly with this. 400 to 800 milligrams is completely fine. All right, let's move on to lifestyle modification. So one thing to consider is bright light therapy, especially in patients who have a seasonal component to their mood disorder, especially again when that sun starts to sink on the horizon and there's not as much daylight. It will activate mood symptoms in a lot of patients, and bright light therapy, again, incredibly low risk. The only downside is the cost of buying a high quality lamp. You don't want to get a crappy one. The good ones are maybe around $150, but it can be very helpful, low risk, to add as an augmenting strategy for depression. Now, in bipolar patients, just be careful you're not activating manic symptoms because there's some possibility it can do that. So with unipolar depression patients, you usually just start 20-30 minutes in the morning. With bipolar patients, you should start with around 15 minutes at noon and move it up to the morning 20-30 minutes if they tolerate the noon dosing without any problems or activation of manic symptoms. Also consider basic bread and butter dietary modifications. So really with someone who has bipolar disorder or is on the bipolar spectrum, their body's going to be so much more exquisitely sensitive to anything throwing their system off. So that will be obviously sleep disruption or time zone changes, but also just blood sugars being all over the place. So just basics of Mediterranean style diet, reducing processed food, reducing caffeine, reducing or eliminating sugar and alcohol. If that's not enough, you could consider an elimination diet. Explaining how to do that is kind of outside of the scope of this video, but at the very least, I would recommend having a patient do a 3-week trial of eliminating gluten and dairy. Then they reintroduce gluten and dairy after 3 weeks, and if they have any sensitivities, there will usually be an exaggerated response, and then the person knows to just eliminate that from their diet. And then it doesn't mean they have to eliminate it forever. You can re-challenge, but usually not for 6 months or so. And again, the obvious, a regular sleep, exercise, and work routine. It sounds obvious, but if you're not actually discussing this with your patients who are bipolar, it's not obvious to them. So explain why their system is more sensitive, especially for young people. Like, yes, your friends are going to the bar, especially college students. They want to be going out with their friends, but they can't do it the same way their friends can. They have to be extra special careful about their routine. Okay, so I hope you found this useful. Again, if you want to get a copy of this protocol, click the link in the description. And if you like this video, you'll want to watch this next one. It'll be somewhere up here, which talks about how to learn integrative psychiatry without spending tens of thousands on a fellowship. I'll see you there.